Think Forward. Think Research Channel.
Thank you, Nora. Thank you for joining us. What I'll try to do in the next half hour or so is just talk a little bit about some of the work that we're doing, in particular with respect to coronary stents, which refer to these slotted tubes or metal tubes that we place in coronary arteries, the vessels that bring blood to people's hearts when they're blocked, and hopefully prop them open and improve the blood flow and relieve symptoms and help people live longer. I will start by mentioning that I don't have any financial relationships with any of the devices or companies that I'll be discussing in this talk. So to give you a little bit of background, first of all, coronary disease is a very common problem, as you probably read about or know about or have loved ones that have suffered this disease. It's the most common cause of mortality in the United States, about 800,000 deaths per year. 7 million adults in the US have symptomatic coronary disease, and the annual cost to the healthcare system is huge, over $75 billion. And what we're referring to, again, are these arteries or blood vessels that supply blood to the heart muscle and allow the heart muscle to pump effectively. And as you see in this cartoon, there are two main coronary arteries. There's a left coronary artery shown here, and then there's a right coronary artery shown here. The left coronary artery divides into two main branches, the left circumflex and the left anterior descending. And so often you'll hear about three vessels or three coronary arteries, and what people are referring to are the two main branches of the left and then the right coronary artery. And when you hear the term triple bypass or quadruple bypass, what that's referring to is someone who has narrowings in 3 or 4 vessels or branches of vessels and has bypasses placed surgically beyond 3 or 4 of those narrowings. And that's been the traditional way of treating coronary narrowings until the past 20 or 25 years, when coronary angioplasty and stenting became available, and we'll talk a little bit about that. Now, what is the impact of coronary disease? Well, what it can lead to is inadequate blood flow to the heart muscle. And this is particularly a problem when people are exerting themselves, like this man shown here, when the weather is cold and the vessels can constrict, when you're carrying something heavy, and just after eating a meal, when a lot of your blood flow is going to other parts of your body, like your gut. And those symptoms are typically referred to as angina or angina. And that's the syndrome of chest tightness, pressure, sometimes radiating to the arm, shortness of breath, that occurs when the heart's not getting enough blood flow because of buildup of blockage or narrowing in the arteries. We have a number of ways of diagnosing coronary disease. The traditional way is doing an exercise treadmill test, where your physician has you walk on a treadmill while monitoring your electrocardiogram or EKG. And what we look for are not only changes in the electrocardiogram, which signify that the heart's getting inadequate blood flow, but also symptoms, blood pressure response, heart rate response, the ability of the patient to exercise, all of those things. There are more fancy ways now available that are likely more accurate for diagnosing coronary disease non-invasively. One technique is called a nuclear perfusion scan or thallium scan that you may have also heard about or read about. And what this refers to is, again, looking at the response to the heart to either stress by exercise or also by giving medication that temporarily stresses the heart. And what we do is inject a radionuclide, or a material that we can see on the nuclear scanner at rest, and see how much of the heart is perfused. This is a cross-section of the heart chamber, and then look at it during stress, shown here, and you'll see that there's areas that aren't as brightly lit. And those are areas that aren't getting the radionuclide because there's a blockage in the artery that supplies blood to that muscle. And so that's another way we can diagnose coronary disease. The definitive way has traditionally been the cardiac catheterization laboratory, where we do what's called coronary angiography. And this is a room where we can use X-rays, and we inject radio contrast dye material directly into the arteries and take X-ray images. And the way we do that is a patient comes into the cath lab, is given some sedation, but is generally awake during the procedure. We freeze up or numb up an area, usually in the groin, sometimes in the wrist, and then insert a small needle into the artery. And through that needle, we can run a thin wire and then remove the needle, and over that wire run a little tube or sheath that we can leave in the artery temporarily. And then through that tube, we can run longer, thinner tubes that are called catheters. And this is a picture of a coronary catheter being manipulated up the main artery in the body called the aorta. And the aorta is the artery which the coronary arteries come off of. And we run our catheter here. This is shown into the right coronary artery, and then we can inject dye and take an X-ray picture. And that's what you see here. On the left is a cartoon of the right coronary, and then on the right is the X-ray angiogram. And in this picture, the artery is normal. You see contrast flowing through normally. But in patients who do have narrowings, we now have the ability to open these vessels up, either using a balloon, as shown here, which is balloon angioplasty, or by placing a stent, where we, on the left-hand side, you see a very tight narrowing in the artery, and then after a stent has been placed, it looks much better. Now, there's been a lot of debate in the medical literature, but also in the lay press, about the role of stents in various situations. And one of them in particular has been in comparison to the standard method of treating patients with multiple narrowings in their arteries, which is coronary bypass graft surgery. And in patients who do have multiple narrowings, we often will prefer bypass because we think it has a more durable or long-lasting result. And if the main branch of the left coronary, the left main artery, is narrowed, we also often prefer bypass. Again, in this case, because it's such an important vessel, if something goes wrong with the stent, you don't have a lot of protection, whereas with bypass, you've bypassed multiple of the vessels, and if there's a problem with one graft, you still have the other ones to sort of help you out. Now, another area of controversy with respect to stents has been in patients who come in either with chest discomfort that is a stable pattern, or come in with a heart attack, actually. And in patients who are having heart attacks, there is now fairly clear data that having a stent placed helps prolong your life and improve outcomes. And this chart here shows a summary of a number of randomized studies that have been performed comparing using stents or angioplasty to using medications, to so-called clot busters or thrombolytics that break up the clot that causes a heart attack. And what you'll see is that the group that was randomized to the stents, shown in these white bars, had lower death rates, lower recurrent heart attacks, lower recurrent chest pain, and overall lower rates of death, stroke, or heart attack. So this is one area where stents have fairly clearly been proven to be beneficial, and there's not too much controversy. An area where there still remains a significant amount of controversy, and the area where most stents are being placed, is in people who are stable, who come in to see their physician and complain of chest pain and either have a stress test or maybe go directly to the catheterization laboratory and are found to have a narrowing or more than one narrowing, and then receive a stent. And this New York Times article and many others like it from a couple of years ago were published after a big study came out suggesting that treating patients like that with medication was equally beneficial, and that stents were being overused. And in many cases, that's probably true, but there were some issues with this trial that got all this press. It was called the Courage trial, and I'll just go through some of them. Basically, it was a comparison of placing stents in people who had coronary narrowings to medical therapy. And it was included over 2,000 patients, and they were randomly assigned to one treatment strategy or the other. And after almost 5 years of follow-up, there was no significant difference in the chance of a patient dying, having a heart attack, or a stroke between the two arms. So the conclusion of the authors was that medical therapy is equally beneficial. One caveat to that is that early on, at least at 1 and 3 years after enrollment in the study, patients who were assigned to the stents did feel better. They had less chest pain compared to those people who were being randomized to medical therapy. There were some limitations that should be highlighted. There were over 35,000 patients screened to participate in this study, but only 2,200 included. And so that gives you an idea that this was a very select population, and it might not be broadly applicable to all types of patients who are coming into the clinic or the cath lab. Many high-risk stable patients were not enrolled either because of physician preference or patient preference. And one important point is that the decision about whether or not to place a stent was based solely on the angiogram and any non-invasive stress test results. And although I just said that the angiogram is our gold standard for diagnosing coronary disease, it has a number of limitations, and we've been doing some research to highlight some of these limitations and show that there are some what we think are better ways of identifying who actually needs a stent or not. And so the next part of the talk, I'll just mention a few of these techniques for going beyond angiography, to look inside the vessel and see exactly what's going on and help us better decide whether or not a patient really needs a stent. One of those methods, which was designed and many of the preliminary studies performed here at Stanford by people like Paul Yock and Peter Fitzgerald many years ago, is intravascular ultrasound. And this is a catheter or tube that has an ultrasound probe near its tip, which allows one to look inside the artery using sound waves and getting an idea regarding the size of the vessel, the amount of buildup of plaque, the type of plaque in the vessel. And this cartoon on the right shows how you can take these pictures and make measurements and get you further information about how narrowed a vessel is. And many times on an angiogram, a vessel will appear normal, but when you put an ultrasound in, you'll see that there's a lot of disease there. It's also quite useful after placing a stent to determine if the stent is in the right spot, well expanded, and whether there are any tears at the edge of the stent or any other complications that need to be addressed. An even newer technique called optical coherence tomography, or OCT, is a wire-based method of looking at the arteries, and it's analogous to ultrasound, but instead of using sound waves, it uses light waves to look at the vessel, and because of that, it has very high resolution, about 10-fold better than intravascular ultrasound. And so this is another device that we're testing currently at Stanford, and what it may allow us to do is actually get an idea of the histology of plaque, meaning the type of cells that are making up the narrowing that you're seeing. And this may allow us to better identify patients who are at higher risk for what's called plaque rupture, and that's the event that often precedes a heart attack or a myocardial infarction. And by getting this very fine details, we may be able to better treat patients before an event happens. That's still very investigational. The last technique, and the one that I want to spend the rest of the time talking about, is looking at what's called coronary physiology, or the flow and pressure down a coronary vessel. And this is quite important because on an angiogram, you might see a narrowing that is, say, 50% or so. And in one patient, that may have a big impact on the blood flow getting to the muscle supplied by that artery. But in another patient, 50% narrowing might not have an impact at all on the artery. Enough blood may still be getting there. And the angiogram is unable to distinguish between those two scenarios. Whereas this device that's called a coronary pressure wire is a wire with a miniaturized pressure transducer near its tip. And we can place the wire in the vessel beyond the narrowing, and we can measure the pressure of the blood flow there and compare it to the pressure at the beginning of the artery. And in a normal artery, those pressures should be the same. But as you can imagine, just like a pipe that might be plugged up with rust or other crud, you'll have low pressure at the other end. The same thing happens with the coronary arteries. And we can display that as shown here, where this purple line is the pressure reading beyond the narrowing, and the red line is the pressure reading at the beginning of the vessel. And you see that there's a big difference in the blood pressure. And that ratio of the distal pressure to the proximal pressure is termed fractional flow reserve. And it's normally, like I said, 90 to 100% of the blood that should be getting there actually gets there, and the FFR will be 0.95 or 1.0. When there's a significant narrowing, it'll drop down to 75% or less, and it'll be 0.75 or 0.70. And that tells you that that artery is compromised and not enough blood flow is getting there. And it helps guide you so that you know that this vessel actually needs a stent, whereas another patient who has normal flow there may not need a stent, and they may get placed for no reason. So I'll show a case of a patient that helps highlight how this can be useful and how it guides us in deciding who actually needs a stent. This is a 50-year-old man who had high blood pressure and high cholesterol. He was awakened by chest pain, and this was the third time that this had happened in the past week. And this episode was persistent and bothersome enough that he decided to come to the emergency department, where an EKG or electrocardiogram was done, and it was normal. But because of his risk factors and his symptoms that he described, the feeling was that he should be watched overnight to make sure that he wasn't having a heart attack. And indeed, it turned out blood tests showed that he did have a small heart attack. And in patients like that, we generally elect to do a coronary angiogram to determine the cause of the heart attack. And so that's what happened in this patient. This is his right coronary artery. And what you may notice is up here, right where we're injecting the contrast, it looks a little hazy, and there's some degree of narrowing compared to the rest of the artery. I'll see if I can freeze that. So right about here is what I'm looking at. Oh, I guess you can't see that, my pointer, but anyway, this area up here. And many people would go ahead and put a stent in there thinking that that's critical, and it may be critical, but again, it's a moderate narrowing and it's hard to tell for sure. When we look at the left coronary artery, it doesn't show so well, but again, there's another moderate narrowing in the mid portion of the heart right there. I'll try to freeze that. And so this is the dilemma that we often face, and patients, for example, in the COURAGE trial may have gotten 2 stents here, and the question is, do they really need all those stents? And anytime you put in a stent, there's a chance for a complication and further adverse events. So let's go back to the talk. What we did was we placed the pressure wire into the right coronary artery, and we measured the pressure beyond that area of moderate narrowing that I showed you and compared to the pressure in front. And you see that that ratio is 0.89, meaning 89% of the blood flow that should be getting there is getting there. And that reassured us that's a pretty good value. Anything less than 75%, we start to get worried, but 89% is almost normal. So we felt very confident leaving the right coronary alone and avoiding an unnecessary stent. On the other hand, when we place that wire in the left anterior descending artery, or LAD, the ratio is significantly lower, 0.59, meaning 59%. And so that's dramatically compromised. And so for that reason, we went ahead and placed a stent there. And this patient's symptoms were nicely relieved. He was discharged from the hospital, and he's been doing well in follow-up. Now, this technique has been evaluated in some randomized studies, and in this one study in particular called the DEFER study, the investigators took a number of patients who had similar scenarios, chest pain with intermediate narrowings on the angiogram that weren't clearly critical, but many people would place stents, and they randomized them either to a stent, which they called the perform arm, shown in red here, or defer, where they managed the patient medically. And these were patients who had an FFR, or fractional flow reserve, that was above that cutoff of 0.75. And you'll see that the patients who were deferred had a 3.3% chance of dying or having a heart attack at 5 years, which was numerically less than the people who ended up getting a stent anyway. So this study, again, reassured physicians that we can rely on this technique, and we can feel safe that even though on the angiogram you might see something, that medicines will work effectively in that group. The flip side is if that FFR is low, you ought to do something. And this was a study that looked at patients where they all were managed medically. None of them had stents, but the FFR was measured, and those that had a low FFR had a significantly higher chance of a major adverse cardiac event at 1 year. So this is a nice way, again, for helping us distinguish those lesions that are the dangerous ones from the ones that are more benign. Now, the area where this is most helpful is people who have multiple narrowings in their arteries. If someone comes in with classic symptoms, they have an abnormal stress test, and they have a 70 or 80% narrowing in one of their arteries, and that's it, then it's pretty straightforward. You know, each point leads to the next, and you put a stent in, and they often feel better. The issue that often comes up, though, is people will have 2 or 3 narrowings, and maybe one is real tight and the other 2 are in the 50-60% range. And then we're left with the dilemma of, well, which ones of these is significant and what do we need to do? And so there were some older studies, retrospective, that looked at using this pressure wire to help guide that decision and suggested that it led to better outcomes than just believing your eyes and basing the decision on the angiogram. But again, these were small, non-randomized studies, and so we set out to do a prospective, large randomized study that was called FAME, standing for Fractional Flow Reserve versus Angiography for Multi-Vessel Evaluation. And the idea in this study, basically we were looking at people who had at least 2 narrowings that were 50% or greater, and the operator doing the procedure would declare, okay, these 3 spots I think are significant and I'm going to place stents. And then the patients were randomized, and they were either randomized to what was termed angiographic guidance, where the operator went ahead and placed the stents based on the angiogram, or to FFR guidance, where the operator used this pressure wire and got more information about the hemodynamic significance or the pressure drop across these narrowings, and then placed stents only if they were critical. And this was a multi-center study that was partly coordinated at Stanford, partly coordinated in Europe, including over 1,000 patients. And the main endpoint of the study was looking at the chance of dying, having a heart attack, or needing to come back to the cath lab for a repeat procedure at 1 year. And what we found was, first of all, those patients that were randomized or assigned to this FFR guided strategy, where the pressure wire was used, they had a better survival rate, less chance of having a heart attack, less chance of needing to come back to the cath lab, compared to the patients who were assigned to the angiographic guidance alone. So they had improved outcomes. They were lower costs too. During the procedure, there was about $700 less used because fewer stents were placed in those patients. Although there is a cost for using this pressure wire, but it was offset by the stents. Also, the contrast material which we use was significantly lower in the FFR guided group, and that may not sound like a big deal to you, but For people who do this procedure, it's quite a big deal because the contrast can damage the kidneys, which can be a very big problem if someone develops kidney failure. And so anything that we can do to decrease the amount of contrast we use is felt to be very beneficial. And finally, it didn't delay the procedure. One of the perceived reasons or arguments about not doing this test is that it adds time and expense, but in both groups had exactly similar time. And again, likely that's because it does add a little bit of time to measure the pressure, but you save time by not having to put in as many stents. In conclusion, the main point I'd like you to take home is that coronary disease is still a very important problem and cause of morbidity and mortality. We're learning more and more about it every day. There are patients who do need to have coronary stents to help open the blocked arteries that are causing symptoms. But I think there are more refined techniques that we're learning about and hoping to implement more and more to help guide us in this strategy. And some of those are physiology, like I talked about. Others give us structure, and others give us biologic information. So FFR, or the pressure wire, gives us the physiology. The ultrasound can give us the anatomic or structural information, and the OCT can give us the biologic information we'll see that may help us treat our patients better. So thank you for your attention. I'm happy to take any questions. The question was that a friend of his has 10 stents in his body, and he can't see where all those stents would fit. Now, it is possible to get 10 stents into the coronary arteries. It's unusual, but the stents come in various sizes, and so you can put 3 or 4 stents in one artery, and so you have 3 arteries. You can get up to 10, but this term stent is also a generic term, and people have stents in other arteries too, sometimes in the arteries to their kidneys or their aorta or arteries to their arms or legs. So it may be that there's a few stents in, not just in the heart, but in other places. So the question is it true that plaque can occur in one organ, but not in others, and why might that be? It is true, and but most commonly, people who have plaque, for example, in their coronary arteries, they are definitely at higher risk for having plaque in other arteries, whether it's their carotids or their legs. So it does, you do have a higher association between that, but there are instances where people will just have it in one place, and we are not sure why. We think certainly some of it, the reason people develop plaque is due to systemic factors like high blood pressure, diabetes, high cholesterol, smoking, but there must be more to it than just that, right? Or else we would get it everywhere. And so likely there are other issues like local inflammation that occurs, perhaps in just some vessels, but not in others. Also, the flow of blood through various branches may stimulate development of plaque, and that may happen in some arteries and not in others. One of the really interesting questions that people have been trying to answer for years is why what's called the internal mammary artery or internal thoracic artery does not develop plaque. That is one of the arteries that's used for coronary bypass, and it has a very good rate of staying open and free of plaque, and we still don't have a good understanding of why that is. So we still have a lot to learn, but yeah, that is true that it can happen just in one spot and not in others. For sure. So family history is a critical risk factor to developing coronary disease, and it is amazing how we'll see young people who have no risk factors, who are very active, exercise all the time, don't have any bad habits, yet they have coronary disease. And likely it is genetic, and a number of studies are being done to try to investigate exactly which so-called polymorphisms and other things like that may be contributing to this predisposition in some people. So the question is, just to repeat it, that the Berkeley Heart Lab was concentrating on the size of the so-called LDL, or bad cholesterol, and small dense LDL being worse than larger, less dense. And that is true. but it hasn't panned out from a clinical standpoint to be a great way of distinguishing patients. There's still so many other variables that we look at, but it is something that's being actively investigated still. The question is, are there differences between men and women with respect to how the plaque is laid down? There are sex differences, particularly things like the timing of the development of coronary disease. Women tend to develop it later than men, 10 or 15 years later, likely related to hormonal changes and the protective effects of hormones in them at a younger age. As far as the distribution of plaque, it's not clear that there are really that significant difference. One area that there is a big difference is the way women present compared to men. It seems that women often have what have classically been termed atypical symptoms, just because men have been studied the most in early trials. So the way men presented was termed typical, which is this chest pain radiates to the arm. Women may present just with shortness of breath or with nausea or other symptoms that aren't quote unquote classic. So that's one of the big differences between men and women. Yeah. So the question is with respect to obstructive sleep apnea, a syndrome that people can develop where particularly at nighttime when they're sleeping, they have periods of what's called apnea where they don't breathe as frequently as they should. And this syndrome has recently become recognized as a risk factor for heart disease and can play a big player in the development of heart failure and pulmonary hypertension, high blood pressure in the lungs. So there is a definite association, and it appears that successful treatment of that can improve that situation too. So it is something that we're starting to pay more attention to and screen patients for, and then try to aggressively treat. Yeah, diet plays a key role in the development of atherosclerosis. Exactly what the best diet is still open to debate, but certainly the American Heart Association suggests a low-fat, low-cholesterol diet. This so-called Mediterranean diet has gotten a lot of press and appears to be a beneficial type diet. I think that diet is clearly important, but particularly here in the United States, one of the really important things is just eating less and exercising more. And if we could, certainly eating healthy is critical, but also if we can remind, especially our youth, about eating less and exercising more, that'll go a long way to improve things. So the question is, what's the smallest size vessel that we can put a stent in? And currently we have stents that go down to 2 or 2.25 millimeters in diameter. And so that is about the smallest size that we can get. The question is, what's the average lifespan of a stent? Hopefully it's for the rest of the patient's life. There is a risk that, first of all, once the stent is implanted, it can't be removed. It's there for good. And the main risk is that re-narrowing can develop within the stent. Plaque or scar can grow through the struts of the stent and cause re-narrowing. The chance of that happening during the first year, depending on the type of stent and the type of vessel, is maybe about 5%. And that's using the most up-to-date stents, these so-called drug-coated stents. Subsequent years, there's still a risk, but it's less, maybe on the order of 1 or 2% per year. So there is a fair chance that it can re-narrow. If that happens, we can go ahead and try to open it up again or put in another stent if necessary. But if you make it through the first year, then there's actually probably a greater risk of developing a narrowing elsewhere in the body, or just as good a risk as it is of having a problem with the stent. Yeah, so the question is an excellent one about whether there are patients who can have heart failure without having narrowings in their arteries, and is there a relationship? And Heart failure or congestive heart failure refers to when the pump isn't squeezing as effectively as it should be. And there are a number of causes. The most common cause is coronary artery disease and people having narrowings and developing heart attacks where the muscle dies and therefore isn't able to pump as effectively. But there are a number of other reasons that people can develop heart failure. And particularly as we get older and many of us develop high blood pressure, the heart muscle itself can get stiff and thick, and we can get what's called diastolic dysfunction, which is another common cause of heart failure, where the arteries or the blood flow to the muscle is normal. It's just the muscle has changed because of long-standing high blood pressure. Other common scenarios are things like alcohol or other drugs, which can affect the ability of the heart to pump. Sometimes people can get infections that can cause inflammation in the muscle and cause the heart not to pump well. So there's a long list of reasons why people can develop heart failure. There can be things that can infiltrate the heart too that can affect its ability to pump. But again, the most common cause is narrowings in the arteries. Okay, thank you for your attention.
Think Forward. Think Research Channel.